So, today is a very special day on Sushi Talks because we have the privilege to host one of the most eminent neurosurgeons in our country, straight away from NIMHANS, Dr. Chirag Jain. How are you, sir?
I'm good. How are you? How are you doing?
So now I'm better after you accepted my request of holding this session because, like in our country, most of the podcasts they are now diving deep into like health topics, but I think it's our responsibility to dive even deeper and get into the nuances of all the subjects. And brain is a very fascinating organ, and I hope you will be able to enlighten all our neurons today and stimulate them also. So first of all, why did you take neurosurgery? Like everybody, like when we enter MBBS, most of us want to either be a cardiothoracic surgeon or a neurosurgeon. But once we approach the internship, we realize that that is the path of like the most resistance. So what was your motivation to do so?
Okay, so I think the point where it started it all was when I was maybe around 8 to 10 years old. So at that time, I don't know, I think everybody has a fascination with something slightly complicated and complex where you just don't understand what's exactly happening. So that's where it started. I wanted to like operate on the brain and see what happens. And you have this idea, that you want to be a neurosurgeon, even though you've never seen a brain, you have no idea what neurosurgery is like. But for some reason, that stuck, and it has stuck through all this time, right? So even through MBBS, even through the entire residency, that idea was just like stuck in my head, and thankfully it worked out. Thankfully, I like what I do, and it's ultimately yes, it is difficult, and it is definitely a path of the greatest resistance. But you know what? If you enjoy doing it, there's probably nothing better in the medical field than this.
So, according to you, who should take neurosurgery and who should not? Because there are like characteristic traits of a neurosurgeon. So,
Right. So I do not believe that neurosurgery is defined by one characteristic trait. The most defined trait of a neurosurgeon would be how egoistic they are, but it's definitely not about that. So I think a more important thing is patience. Really, you need to spend time. Okay, you're going to be stuck in a surgery for maybe 4 hours, 5 hours, 7 hours, 10 hours. So that is definitely going to happen at some the other point in your career. So patience is definitely important. But I think apart from that, there's no defining characteristics. The most important thing is you should really, really want to become a neurosurgeon. That is the thing because it is a long journey. It is going to take you time, right? It is going to take at least 6 years of residency to end up on the other side and say that okay, you're a neurosurgeon. And beyond that, at least 10 to 20 years before you can confidently say that you are a neurosurgeon, because it takes that much time to get that much level of expertise, operating on the brain and the spine. So you have to be really, really confident about the fact that you want to take up neurosurgery. It is definitely the most grueling residency there is there. So unless you're sure, please don't get into it.
okay, so my dad is an orthopedic surgeon, and he has always like told me that you should become one. Like it's my job to become like an orthopedic surgeon. It is already predestined. But like he told me ki I have already asked him ki why not neurosurgery, why not plastic surgery. So like he told me ki it is very fine and nuance based. Is it true? Like all the surgeries of neurosurgery require like good dexterity, or is it just a misconception?
Okay, so if you're not going to touch the brain, you don't really require that much dexterity, right? And if you're working on some very like as general as you can get in neurosurgery, you're doing trauma. If you're doing like big tumors that you can just see with your naked eye, yeah, you can. Or maybe you don't require as much dexterity, but it is true. Ultimately, we do work with microscopes, and if you're working with a microscope and it's something your eye cannot even see, so you can just imagine like how much fine motor control it requires to take out whatever pathology you're trying to take out. So yes, plastic surgery, neurosurgery, even ophthalmic surgery, a lot of that does require a significant amount of dexterity. But there are a lot of things you can do in neurosurgery without a microscope. So just trauma surgeries, chronic subdurals, shunt surgeries, some spine surgeries. A lot of them can be done without a microscope. And I don't think that to be a neurosurgeon, you require a microscope or you require the highest level of technical skill possible. It is possible to be a general neurosurgeon without all of that.
Okay. So, sir, let's say somebody wants to be a spine surgeon. So, should they take the orthopedic path or the neurosurgery path?
Okay, so that is a controversial and a complicated question. Okay, so it really depends on what you want to do with spine. Okay, so if you want to operate on discs, you want to operate on deformities, you want to operate on the pathology you're going to regularly find in the outside world, orthopedics is not a bad option. Okay, it has taken over a significant part of that. Discectomies, deformities, fusion surgeries, all of that is significantly done in orthopedics now. If you want to operate on the nerves which are running there, you want to operate on the spinal cord, you want to get into the tumors over there and the pathology inside that, you would definitely have to be neurosurgeon. You cannot get inside the dura
Okay.
without being a neurosurgeon. So that is for sure. Ultimately, there's a lot of overlap. Okay, you will not see neurosurgeons and orthopedicians working together. That is an ego clash just
Clash
waiting
of
to
the
happen.
egos. Yes, yes.
So that is very unlikely to happen, even though it should technically be the ideal possibility where both of them work together to make it happen. But especially in a country like this, you're not going to see that happen. But if you want to, if you're just fine with working with discs and fusion surgeries, orthopedics is a good option for you.
Okay. One more uh, particular problem that I have faced when it comes to choosing between neurosurgery is that I've heard, like I might be wrong, sir. Please correct me here. That you have to deal with death a lot. So is it true? And if like most of your patients are moribund or like if the mortality rate is high, so how does it affect you and how do you deal with it?
Right. So I would say my clinical exposure more or less started with neurosurgery. I had a significant amount of exposure even before that in the internship, but more or less the actual clinical exposure and expertise started with neurosurgery. And honestly speaking, at the end of the day, neurosurgery does have a higher morbidity and mortality than most other fields. Okay, especially if you compare it to, like, say, dermatology or plastic surgery or any other less morbid field. Yes, if you compare it to oncology, it's probably got a better morbidity and mortality rate, though. It really depends on what you're looking at. So at the end of the day, neurosurgery is about making the patient slightly better. Okay. So it's not like you're not going to achieve some miracle where everything's fine. Okay, that's most of the time that's the case. You're trying to achieve whatever's the best possible outcome, and there is somebody required to do that, and that is your job. Okay, so like your job is just to get in, do the best possible thing you can, and get out. Right. So that it is going to be a slightly higher morbidity and mortality, but somebody has to do that work, and it does require some technical expertise, and it does require a lot of patience and a lot of effort. And honestly speaking, when it works out really well. Okay, so the results can be excellent, but when it bombs, it can also be quite bad. So again, there are two sides to a coin, and we have to accept that.
Okay, very well said, sir. Sir, in the life of a neurosurgeon, just explain like how your day goes about and what are your bread and butter cases.
Right. I think I'll just explain what a normal residency day would look like. Obviously it's a little bit different for a person who's doing a residency and is a consultant. So if you were ever to do a neurosurgery residency, most likely you'll be waking up quite early. You'll be waking up around 5 at least, and after that, maybe the hospital starts at 6. You go in. You take some rounds. You see the patients that you might have operated yesterday, and then after that, if you go into the OT, most likely you're operating one or two cases that might go on from around 8 or 9 to maybe 4 or 5, sometimes even till 6, 7, sometimes even till 10, 11. So that is possible, not every day, but it is possible for that to happen. After which it'll be again rounds and then working on preparing for the cases which are going to happen the next day. Overall, time spent in the hospital maybe around 13 to 14 hours, or maybe even more, depending on which part of the residence you're in. If you're a consultant, more or less works, it depends on where you're working, private sector or government sector. But I would say maybe around a 10 to 11 hour workday might be a regular thing for you. If you're also part of the emergency team, it might be slightly more hectic. You might be called into duties at night, which is a significant part of the job with neurosurgery, particularly. If a patient comes in, you have to come in at whatever time of the night it is. Right. So that's a very common thing with private jobs in neurosurgery. The bread and butter cases are mostly, I would say, 25 to 30% of neurosurgery is neurotrauma. Okay, so that is the biggest part, especially in a country like India where people are just like riding around without helmets and just falling down here and there. The most common cases you're going to come across is neurotrauma. Apart from that, neuro-oncology makes up a significant part of neurosurgery.
Okay.
So tumors everywhere, brain, out of the brain, spine, peripheral nerves. So those are two most common cases you're going to come across.
So now let's dive deep into the topic of head injury. So first of all, can you tell me the do's and don'ts which a person, let's say the patient party, should follow in case of head injury?
So I'm assuming you're asking about do's and don'ts before the head injury happens or like after the head injury?
Just like let's say one of my relatives fell down and like a head injury has occurred. So what should the patient party do before coming to the hospital?
Right. So all of that really depends on what is the condition of the patient. Sometimes they're awake and they're conscious, and sometimes they're not awake and they're not conscious. If you're awake and you have fallen down, you have injured your head. So the most important thing is don't eat food and don't drink water.
Nil per
In
oral.
case Yes, so that applies, I think, to any injury of any sort. You never know if you're in any surgery or not. So just don't eat anything, don't drink anything. Come to the hospital, a doctor will evaluate you, figure out if you require a scan or not. And then once a scan is done, it is more or less clear as to what is to be done after that. The only thing is just like don't fall again. That is all. Right. So repeated falls is definitely one of the major factors which can contribute to long-term neurocognitive sequelae. So you don't want to do that. Other thing is just please, if you're on a two-wheeler, wear a helmet. That's all. I think that's the most important thing. Any neurosurgeon will tell you.
Okay, so we were talking about the like you told me if the patient is conscious or not. So we are taught about the Glasgow Coma Scale. So can you like explain the audience what is the difference between coma, stupor, drowsiness, and consciousness being alert?
Right. So we don't use such subjective terms when it comes to describing consciousness. We do have the GCS or the Glasgow Coma Scale, so that is very defined set points. Like the eye opening can be scored from 1 to 4, motor response is scored from 1 to 6, verbal responses are scored from 1 to 5. So we get a rating scale which goes from 3 to 15. So that is how we talk about all patients in neurosurgery. It will be covered under GCS only. Long-term patients, on the other hand, usually weeks to months after the pathology has happened, we technically do not use the GCS for that. So that is when we talk about them being unconscious or minimally conscious or persistently vegetative or in a coma. So those are defined terms, right? So a persistent vegetative state would be when basically they are just lying there. There is no awareness of the surroundings. They're probably not opening their eyes. They have no circadian rhythm. So when it slightly improves, when they have a circadian rhythm, they open their eyes, they look around, they're slightly more aware. That'd be a minimally conscious state. The more and more consciousness you accrue, the higher you go up the ladder of consciousness. But with neurosurgery, it will be the GCS that is talked about when you're talking about consciousness. You don't talk about it in subjective terms.
Okay, so regarding like helmet injuries, like people on two wheelers, they do not wear helmets and everything, and they can lead to like different types of hemorrhage. So can you describe the different types of hemorrhage and how is the management of let's say subdural hemorrhage different from arachnoid hemorrhage and epidural hemorrhage?
Right. So the most common injury that is going to happen usually, if you've fallen down and you've injured your head. Okay, so some of the most common injuries would be an epidural hematoma. Less likely injury, but a more significant injury is a subdural hematoma. And another thing you can develop is a contusion. Okay, so these are three most common injuries you'll have within the cranium. Outside the cranium, you can get scalp lacerations, you can get scalp abrasions, and scalp contusions, which are nothing to worry about. Somebody will stitch that up for you. Within the skull, you can obviously get skull fractures. The only cause of concern with a skull fracture is if it is involving a air sinus. If it involves an air sinus, it can also involve the dura. If there's a dural tear, then you can have CSF leaks and you can get infections. Okay, if it involves a skull base, you can get multiple cranial nerve palsies, so that can happen, right? And if we go inside the skull, then that's when you can start developing your hematomas. So if there's a collection of blood which is happening between the skull and the dura, that is called an epidural hematoma. If it's below the dura and between the brain, then it's a subdural hematoma, and if it is within the brain, it's a contusion, right? So, and there are different treatments for all of these. Epidural hematomas are the most concerning, okay, because the thing is, usually they happen from the middle meningeal artery rupturing. And if that happens, the blood is under a significant amount of pressure and it compresses the brain really quickly. So you have to get in urgently and remove it immediately. In most cases, if it's large enough, right? So that is the literally the only actual absolute emergency neurosurgery. It's an EDH. Okay, everything else can wait slightly. Okay, but the most absolute emergency you'll ever come across in neurosurgery is an EDH. Apart from that, subdural hematomas, the problem with subdural hematomas is they require a significant amount of trauma, okay, to occur. And when they occur, it also means that the other parts of the brain have been significantly injured, even if you cannot obviously see it, right? So there's usually a component of diffuse axonal injury or diffuse cerebral edema which sets in with subdural hematomas. That is why the patients who have subdural hematoma, even if you remove the entire thing, there's a very good chance they might not do as well because the entire brain is more or less injured. Contusions happen in certain areas of the brain, most likely in the frontal or the temporal lobes, because that's the part which is against the bone, right? So when it hits, you get most commonly contusions in those regions. If they are in some areas where there's no significant function, like if they're in the right frontal pole, it's okay. I
Okay.
mean, if large enough, you remove it. If it's not, it's fine. You can just observe. The problems arise when they're in areas where you have function, right? So if they're in speech areas or they're motor areas, they can cause problems. Um, there are some defined criteria for when you operate them surgically and when you don't. I think that's like pretty researchable online if somebody wants to know on Google.
Cool. Sir, so we have been taught about one particular concept which is like very cool, according to me at least. So can you tell the audience about what a lucid interval is?
Okay. Right. So when the injury happens, if you fall down, at that moment, you'll develop a concussion. Okay. So you just like you black out, you lose consciousness. And after some time, you recover the consciousness. Okay. So you've come back to your senses and now you're fully alert, you're fully conscious, you're going about your day, you're saying, telling everybody you're fine, nothing is wrong. Okay. After some time, okay, and most likely this happens in the case of an extradural hematoma. So the blood from what are most likely middle meningeal artery is going to continue bleeding into the space. And when it becomes large enough, it will cause some sort of herniation. Okay. When that herniation happens, again, you lose consciousness. Right. So you have that interval in between where you were lucid. So the first one was just a direct result of the head injury. You developed a concussion, or you developed just like a significant amount of trauma, which knocked you unconscious. Okay, you regained consciousness, and then again because of the herniation related to the extradural hematoma, that is again when you fall unconscious, and that is what's called a lucid interval. Most likely seen with epidural hematomas.
Okay, sir, I'm so sorry, but I'm gonna mix some forensic medicine for a neat aspirants in it. So, if let's say a person commits some crime during the lucid interval, so can they be prosecuted for that?
Right. So, in a lucid interval, you are technically and medically speaking and ethically speaking, you are responsible for your actions. It is not like you have developed an altered personality or your judgment is impaired unless you have uh, radiologic evidence that your frontal lobe has been damaged or maybe some part of your brain has been damaged significantly to cause a neuropsychological alteration. So you would require that patient to undergo a neuropsychological assessment, figure out if there is some alteration of neuropsychology, and then only we can comment on whether this action which was done is has been done secondary to the changes following trauma, or it is just an act done by the person itself. But technically speaking, if an act committed during the lucid interval, you should be held responsible for it.
Okay, I'm gonna keep that in mind. Okay, so one more thing. You were talking about herniation. If I'm not wrong, there is one particular concept which is known as the Conance Notch phenomena. if I'm not wrong. So can you explain that also for all the NEET aspirants watching right now?
Yeah, sure. That's it's a straightforward thing. So basically, I'm sorry, is there like a whiteboard here I can use? So the basic idea is, for example, if you imagine that this is the medial edge of something known as a tentorium cerebelli. Okay, so the tentorium is basically a fold of the dura, which is going to separate the supratentorial and the infratentorial space. So basically, the posterior fossa and the middle fossa. Okay, in the middle of it, you're going to find the brainstem over here. Okay, not the best diagram just put up with this place, right? So this is the brainstem, and this is your tentorium. Okay, so this is the medial tentorial edge on all sides. So what happens is with any sort of herniation, especially transtentorial herniation, you're going to get the medial temporal lobe and its uncus falling onto the brainstem over here, right? So this area of the brainstem is where the cerebral peduncle is.
Okay.
Okay, and when the uncus falls onto the cerebral peduncle, it is going to cause compression on the cerebral peduncle, and then it will compress the corticospinal tract. For example, if you assume this is the right side, okay, so it's compressing the right corticospinal tract, and you're going to get left side weakness.
Okay. Contralateral weakness.
Yes, contralateral weakness. Now imagine that it has significantly compressed the brainstem and it has pushed the brainstem to the opposite side. So your opposite side tentorium is compressing the left side peduncle instead. Okay, so if it's compressing the left peduncle, it's compressing the left corticospinal tract, and you get a right side weakness. So ipsilateral weakness, your pathology is on the right side, and you're getting the same side weakness.
Yes.
This notch formed by the tentorium is known as the Conance notch. So that is the whole Conance notch phenomenon.
Beautifully explained, sir. Thank you so much for this. Now, I think my doubts are also cleared. Sir, let's move on to a very interesting topic of brain tumors. So, what are the most common brain tumors which are present in the Indian population, and what are the signs and symptoms to look out for?
Right. So the most common intrinsic brain tumor is going to be a glioma. Okay. So a glioma is a parenchymal tumor. It arises from within the brain. The second most common, or almost the same with frequency are meningiomas. Okay, so significant difference between both. Meningiomas are more likely to be benign. Gliomas are more likely to be malignant. The most common glioma is the glioblastoma multiforme. Right, so that is those are some of the worst tumors. Average survival is around, depending on the type of GBM, maybe 9 months, maybe 15 months. With meningiomas, at least you have like if it's been removed and it is just grade one, you can live lifelong. Okay, whatever the rest of your life. Okay, so with brain tumors, it is a long and a long topic, right? The only thing that the most common presentation of a brain tumor is a new onset seizure.
Okay.
Okay, so for all brain tumors, right? So if you have a brain tumor, the most common symptom you're going to be presenting is a seizure. Okay, so if you develop a seizure and you've never had a seizure before, especially if you're an adult, you should always get a scan. Okay, that has to be evaluated with a scan. Other features you might have are some headaches you get on a regular basis. You get a daily headache, especially in particular areas of the trigeminal nerve. If you're getting a frontal headache, especially on one side, if you're getting a headache involving either the maxillary or the mandibular division, right? So those can be a little bit concerning signs also. Sometimes you might get what are known as raised ICP headaches. Okay, that is if the tumor is big enough that it is actually causing intracranial hypertension. These headaches are worse when you get up in the morning, okay, and when you've just woken up from sleep, and they cause you to have vomiting and blurring of vision. And once you do vomit, you feel better. And so it's a very classically defining feature of a raised ICP headache. So and definitely, if you develop focal neurological deficits, you're going to be going to the doctor and getting checked out anyway, right? So some things people tend to ignore and wait for usually are the most subtle signs, like a very small headache. They might develop a little bit of hearing loss that they have not already picked up. Some of the early signs can be difficult to pick up, but especially if you've developed a seizure, please go to the doctor and get it checked out.
Okay. So, before we move on to the topic of productivity, I want to ask you one thing. How are your plants doing, sir? I think it's a difficult.
So the thing with my plants is I feel that some of them want to survive and some of them don't want to survive, and I don't know how much I can help that, right? So I can honestly say that I know that I can save my patients, but I'm really not sure about it. I was just repotting one, and one of them just randomly died. I don't know even know what the problem is. The rest are all doing fine, but let's just like try not to jinx that.
Yes. Sir, I have been following your productivity channel, Grow with Chirag, your for your core follower base, and I have seen how you work by hour, you plan out your days and everything. So where did this mindset come? Was it developed during your MBBS, or like it was before when you were an aspirant, or did you develop a similar mindset during post graduation?
Okay, so the basic concept here is time blocking, I think, and that has been a little bit of a recent change. I would say it's been over the last year, more or less. Like I knew about time blocking, I had tried it previously, but in the middle of a very difficult residency where you're getting only about 3 to 4 hours of sleep, I don't think anybody's going to be time blocking with that, right? You just go to work, you do whatever work you have to do, you come back, you sleep, and then you just get up and go do that again, right? So obviously this whole thing with time blocking and having a schedule and having a to-do list and tracking whatever you're doing every day, it does take a little bit of time and effort, and I think it would be only possible when you do have a couple of free hours a week at least. The mindset of being a little bit more efficient and more productive has developed over the last 5 or 6 years. Yes, I think it all definitely started a little bit with fitness. The main challenge when I started with residency was, when do I go to the gym? Okay. So I think I started with the gym about 7 years ago. That was an internship. It was going on before that also, but it was never that serious. It was just on and off, on and off. Right. So since the last 6 or 7 years, it has been serious, still with few ups and downs. There are times when I've taken longer breaks of a couple of months. But since the last 2 or 3 years, more or less, it's been continuous. And the main thing when I started out 5 or 6 years ago was like, when do I go? And there were times when I was waking up at 4 o'clock, and after waking up at 4:30, I'd be at the gym, and then at like 6:30 or something, I would be at work. And so that's when planning your day and figuring out your schedule and figuring out how to get everything done in a limited amount of time, that mindset sort of sets in. So that's when I started like getting into the whole productivity scene. I would watch some YouTube videos and how to make it happen and how to get things done. I read a few books which I think really helped along the way. So I think all of that overall has led to whatever stage I am at now. No way I would say that it is perfect, or that I know everything at this point. There's obviously a lot to learn. But you know what? I think even the slightest amount of um, just figuring out how productivity works can really help make a massive difference in your life.
So I was diagnosed with attention deficit hyperactivity disorder in class 2, and I was a very fat kid. Like I had a weight of 143 kgs, and I started going to the gym. And in 2 years, I've now I've gone through the process of body recomposition, but academics has always been a thing that I'm not able to tackle properly. I'm a very good student, but I only start studying when like I get that the trigger. Okay, oh my god, my exams are coming, and then I go into that hyper focus zone. So how should a person like me get into this productivity wala thing for academics?
Right. So I don't think what you described is just an ADHD phenomenon. I think it applies to the entire group of students. People study only when they really, really have to. Okay. So I've been doing a lot of research and a lot of like deep dive into how to study, how to retain better, how to improve your memory, and figure out just like what is the right technique of putting the information in there. And the main thing overall is it takes effort. Okay. You're not going to study, you're not going to learn without putting in the effort. And that effort has to be put in regularly. Okay. It is definitely possible, particularly with Indian exams, that you study one day before, 2 day before, 2 days before, and you get through the exam, and then automatically, just like that, everything is out of your mind. It's just like it's been thrown into the garbage, and you cannot remember anything the next day. So that is what is most likely to happen with exams that we do over here. I the best way to really tackle a subject, especially medical subjects, is you have to put in effort over the long term. Right? So throughout the year, more or less, for example, you're in third year, in your fourth year in the MBBS or in your residency, you have to put in a little bit of effort on a regular basis. Okay, so that's the main thing. Instead of struggling right at the end, just struggle 1 or 2 hours a day, right? That's all it takes. Okay, if you do it consistently every single day, it will work out. Okay. The whole thing of how to study, how to make it more interesting to yourself, how to retain it better, how to actively test yourself and check recall, and check if you've really understood the whole topic. I think I will be putting out a little bit more content on that in the near future. So I think you can check on that online, and hopefully, I think we'll be able to cover those topics.
Yes, sir. But I've been like going through all your content. I'm a big fan of the content that you make on Instagram, and you have talked about the protein requirements. You have made a post on creatine also. So how should a doctor who like not, now nobody has an excuse after seeing you, like you have the most gruesome you've been through the most gruesome residency, and you have also tackled your fitness wala thing. So what recommendation do you give to those doctors who say ki I cannot join the gym because I'm in medicine, I have this, I have that? So like how should they change their mindset and belief system, and what should they start doing as a novice?
Okay, so I'll just give you one example. You can have the worst possible residency. You can have the worst day. Um, you can have like a 16-hour work day, and you come back home and you go to sleep. But let's be honest. At the end of the day, when you come back home, you're not going to go to sleep immediately. You're going to watch a bit of Netflix, or you're going to open your computer. You're going to just do something random, or you're going to be sitting on Instagram scrolling reels for the next 1 hour, and then you're going to go to sleep because, like, at the end of the day, you need to find some of the other outlet apart from work, especially when you have such a grueling work day. So when other people were doing that, I was going to the gym. So that's just how it was. It's a personal choice at the end of the day. You can choose, and I wouldn't call it excuses. I mean, it's really not fair. It's not a priority for everyone to go to the gym. Fitness is not a priority for everybody, and that's fine. If you want to go to the gym, you will find a way, whatever it is. You're working. I have gone to the gym after sleeping for 3 to 4 hours. I would not recommend that to anybody, right? But at the end of the day, when it is a priority for you, you're going to find a way to make it happen, right? If it's not a priority, nobody's going to be able to force you and push you into it. Okay, so that motivation is to come from within. Okay, and the problem with the fitness industry is it just assumes that everybody wants to become fit, but they're making an excuse about getting there. It's not. It's not for everybody, right? So, like, let's not assume that everybody wants to get there. Well, the people who want to get there will make it happen. The people who don't want to get there, leave them alone, right? It's not. Let's not shape them into it.
Yeah, that is true. So I think I should also change my mindset regarding that particular thing, because I've been very hard with my audience. I just tell them ki because I've been on the unhealthier side. I wouldn't say ki I'm on the healthier side now, because my caffeine intake is something which I'm not proud of. But this side is more beautiful when you are just pursuing and seeing changes in your body. It just gives you a sense of self confidence and a purpose also in life. But with today's conversation, my purpose in life has changed. I would love to like go through the neurosurgery part of my internship, and to be a great doctor like you one day. So thank you so much, Dr. Chirag, for taking out time from me from your hectic schedule, and hopefully today's talk helps a lot of people out there.
Yeah, it was a great opportunity to come here and speak about what little experience I have. Thank you so much for having me on here. It was a very, very good talk.
Thank you so much, sir.